just to remember that iron deficiency anemia is most commonly caused by not eating the right kind of food. So, you as a nurse should be able to make a fairly extensive list of what iron-rich foods are. In peds, sometimes different age kids eat different kinds of things. So you would need to be able to know what are iron-rich foods that would hit all of those age groups. Okay? If you can copy this down. This is just my talking points to remember because it's what I wanted to talk to you about. So iron deficiency, we need iron-rich foods. Then we need to talk about what those ages are, what those vaccines do. I think when I was around all of your tables talking about the Venn diagram, we talked about platelets being normal for all three of those diseases. Did everybody get that? Okay, look at the person sitting next to you and really find out, did they get it? And if they didn't get it, would you hold up your hand? Because I'm not trying to put anybody on the spot.
Okay. I didn't know it, but I get it now.
So tell me, what's the problem with hemophilia kids?
Clotting factor.
Clotting factor. So it's a factor problem. It's not a platelet factor. It's not a platelet problem. It's a factor problem. Okay? We talked about shortened, decreased life of RBCs. That's a primary problem in thalassemia. When do kids with sickle cell disease have shortened red blood cell life?
When they're in crisis.
So those sickled cells, when we correct whatever the stress was that caused the crisis, whether it was low oxygen, whether it was an infection, whether it was dehydration, those little sickle cells don't pop back open and be nice little donuts. They die. And when they die, we have the shortened red blood cell life. On the answer key, if you will, that laminated piece of paper, the shortened RBC life, because we have those broken red cells, we have iron and all the other globin that are floating around. If we have too much of that, we have excess iron. And when we have excess iron deposited in tissues, what's the vocab word? It's that hemosiderosis. So the deposition of excess iron in tissue, bones, skin, organs. So when you saw in your notes that it said there's a darkening of the skin, it's because we have excess iron being deposited in the skin. Okay? If we have too much iron in the tissues, too much iron in the tissues causes some dysfunction in those organs. Is sometimes unpleasant to look at if the skin gets too dark, has a funny kind of color. But in our bones, it causes those bones to be particularly fragile and brittle and can cause breaks. So because those are complications of hemosiderosis, I want to get rid of that excess iron. And we do something called chelation. The verb is chelate. And there's a drug that we were talking about that does that. What is that drug? Desferal. And so it's a drug that goes looking for excess iron, and when it finds it, it binds with the excess iron, and then what does it do with it? So it's excreted. Okay. How's that concept? Does that make sense to you guys? Okay. The diseases we've talked about today, the red cell diseases, have some fairly specific transmission genetics. So you need to know how to look at Punnett squares. Okay. So the easiest one to talk about, or the one I want to talk about, is hemoglobin S. Sickle cell disease kids. We have people who have the disease, and we have people who have trait. Okay? The most typical type of hemoglobin is hemoglobin A. So this is typical hemoglobin. But there are other types of hemoglobin too, and we could spend a whole course talking about just what hemoglobin does. So I listed for you C, G, O. I mean, there are other kinds of hemoglobin. My point is that if we have somebody who has typical hemoglobin from their mom and their dad, then they are not going to have sickle cell trait, and they're not going to have sickle cell disease. If there is somebody who has sickle cell trait, it means that that S hemoglobin is covered by that typical hemoglobin A and will not be expressed until it is combined with a partner who also has either the disease or the trait, and then we could have an offspring that has the disease. So being able to look at these Punnett squares and being able to tell me who gets it, half of my sons, all of my sons, all of my daughters, who gets it? So with sickle cell disease, is it related to gender?
No.
Hemophilia, is it related to gender? Yes. It is. So being able to look at these Punnett squares, y'all need to be able to do that. Those little extra slides are in this test 1 material because that was the first time we saw it in this course when we talked about cystic fibrosis. But these Punnett squares are a baseline foundational kind of thing as we talk about transmission, genetic transmission of diseases. Okay? All right. With hemoglobin F, and that stands for fetal hemoglobin. Fetal hemoglobin is a protector in the expression of hemoglobin S. So when a baby is born, they have a good bit of fetal hemoglobin. And so babies who are born to a partnership where we don't know that they are going to have sickle cell disease, they will not express sickle cell disease until the hemoglobin F is dissipated. So in your notes, it talks about when you diagnose, and that we don't diagnose little neonates with sickle cell disease unless we have a reason to do genetic testing. Does that make sense? There was a section in your notes related to white cells and leukemia where I talked about intrathecal medication as being a prevention of CNS disease. Why would I put chemotherapy into the intrathecal state? Because what about the blood-brain barrier? You're close. You're really close, Kyrene. So you know about the blood-brain barrier. And you know there's some things that don't cross it. And many of our chemotherapy drugs do not cross the blood-brain barrier. But leukemia cells do. And so what we do is we give chemotherapy on the vascular side, and we give chemotherapy through the intrathecal space to cover both sides of that blood-brain barrier. In your notes, it says we use intrathecal medication to prevent CNS disease. We also use intrathecal chemotherapy to treat CNS disease if it is there. Many times when we diagnose kids with leukemia, they do not have CNS disease at diagnosis. But we don't want them to get CNS disease, and so we will prophylactically use chemotherapy drugs through this route. And so it's just a route issue because the chemotherapy drugs don't cross that blood-brain barrier. So as you think about, some of you have put your Venn diagrams away, some of you have not. But as you think about those symptoms, manifestations, which one of those kinds of symptoms is the muddiest, hardest to understand, not sure you got it? Okay. Somebody asked me about splenomegaly. Y'all have that?
The hydroxyurea.
Hydroxyurea. Hydroxyurea is a drug that increases the production of hemoglobin F. And because I know that hemoglobin F decreases the expression of hemoglobin S, it's a desirable drug. Some of you Googled it, and I just saw that it's a chemo drug, and it is. There are very few drugs out there that we give just for one reason. And so hydroxyurea has some other functions, but one of the things that we use it for is to protect our sickle cell kids from these crises.
Does it have to be given before all of the hemoglobin F is out?
That's a wonderful question, and my understanding, Chelsea, is that by giving hydroxyurea even later, that it can stimulate the production, the reproduction of hemoglobin F. So as you look at that, what other things, symptoms are muddy?
Is frontal bossing just bad?
What's frontal bossing?
There's a picture of it. Big forehead.
So why is the forehead thick? Allison, say it good for us.
Because the long bones are the main ones that produce the red blood cells, and so they can't meet the body's demands, and so the flat bones in the head will start overproducing the red blood cells to compensate, and so that's where you're getting the frontal bossing.
And so it's flat bones, and so flat bones here, our scapula, as well as our pelvis, will also be pulled into that production. But the one of those bones that's most obvious is right here. And so we call it, it's one of those clinical symptoms that we see, that in thalassemia, these kids, their bone marrow is really revved up everywhere. Because when we do bone marrow aspirations, we don't typically go to the flat bones. Other kinds of symptoms on here that seem muddy.
With the hemophilia, the DDAVP, I know that increases the clotting factors, but do you give those in conjunction with clotting factors, or do you give that like before you would give a kid clotting factors?
What I want you to remember about DDAVP is that it causes any stored